So welcome everyone to the September Liverpool Dementia and Aging Research Forum. Today we'll be joined by Dr. Anna Volkmer, who is a speech and language therapist and an NIHR-funded senior research fellow at UCL. She does some fantastic stuff on language-led dementias, which is much rarer than the more common type of Alzheimer's disease dementia. And it's really important for us to hear a bit more about those rarer dementias and their symptoms, how they can be managed. So it's a big pleasure to be joined by you, Anna, today. Whilst we're going through the talk, which will last about 40 minutes approximately, please feel free to add any questions, thoughts, comments in the chat box. We will be picking them up afterwards, about 1:45, have a chat with Anna about them. And if you are on social media as well, please feel free to use the hashtag Liverpool Dementia. So Anna, I can't see you right now, but I know your screen is shared. So if I can move over to you.
Yep, no problem. Thank you so much. Thank you so much for having me, Clarissa. It's been a great pleasure to be invited here today. And yes, so as Clarissa mentioned, I'm a speech and language therapist and a senior researcher, an NIHR-funded senior researcher. I work both clinically and academically, and I specialise in working with people with language and dementia, and my research is really focused on primary progressive aphasia. So I thought it might be useful today for us to talk a bit about what primary progressive aphasia is. I'm going to take you on a speedy tour, as well as telling you a little bit about the research I do and what that might do to help people live better, have better conversations. So I know you all know that dementia is an umbrella term describing progressive cognitive difficulties. And I know, of course, that you all know there are 4 main types of dementia, and there are more and less typical types. So, you know, there's the more typical amnestic type of Alzheimer's disease, where people have predominantly memory problems as their leading symptom. But there are also some less typical types of Alzheimer's, or rarer types, such as posterior cortical atrophy, or PCA, which is a visual-led disease, and logopenic aphasia, which is a language-led Alzheimer's disease. We also have more typical frontotemporal dementias, which are behaviorally led, and less typical frontotemporal dementias, which are language-led, such as semantic dementia and progressive non-fluent aphasia. There are different types of Lewy body dementias. There are different types of vascular dementias. There are hundreds of types of dementia, but I'm actually going to focus on these 3 types. Now, these 3 types, you may have caught it earlier, but these 3 types have in common that they have an aphasia, a language difficulty, as a leading symptom. So we often call these the language-led dementias, or more officially, primary progressive aphasia. Now, I think what's really important to say here is actually we now know that language and communication can be affected across the different dementia types. I may be stating the obvious to many of you, but what we specifically know from some more recent research is that people with behavioural variant often present with what I might describe as a secondary progressive aphasia, but that looks a lot like non-fluent. So this type of PPA down here. And people with Parkinson's disease, they present with both receptive and expressive difficulties, but people with other types of Alzheimer's will often present with language difficulties, a lot like logopenic aphasia. And that's important because the research we do with this slightly rarer type of dementia has got much wider implications for people living with dementias. The potential for it to benefit people across the board is something that we believe very much, very positively in. So I'm going to move us forward a little bit and talk a little bit more on these PPAs. I mentioned that what the PPAs have in common is that they're all language-led diseases, but this is also a very heterogeneous group who have, so these different types of PPA, or primary progressive aphasia, are associated with different protein pathologies, which result in different patterns of disease profiles in the brain, so different patterns of atrophy in the brain. And this is what results in different profiles of language difficulty, different types of speech, language, and communication difficulties. So I'm going to walk you through these relatively briefly. So the first type is semantic variant PPA, and semantic variant PPA is generally associated with a left hemisphere anterior inferior temporal lobe atrophy. You can see it here on the image, and that atrophy is often described as quite knife blade like. And this is a pretty good association. We see this pretty often with people with semantic variant, and it's also associated with this protein TDP type 43, type C, and this is part of the frontotemporal dementia family. So people with semantic variant PPA, also sometimes described or termed semantic dementia, they really have difficulties in semantic knowledge. So that means that when you meet somebody, they often have difficulties in naming objects. Proper nouns are often affected first. And it's not just in naming things, but also in understanding things. And what you often find, often a really useful hallmark symptom, is that these are people who will be able to repeat things fluently and phonologically accurately. And so they'll often say things like, what is chicken? What is a sibling? When you're in conversation with them. So finding out from the person or their family if that's something, or observing whether that happens, can often be a really useful flag. Over time, people will develop more and more difficulties in this area of object knowledge, in their semantics. So they will develop more and more problems with understanding object functions. They may find it harder to recognize objects and know what to do with them. And we tend to find that less familiar objects and words are more likely to be impaired first. So there's this frequency effect. We also find that people with semantic variant PPA present with reading difficulties. So surface dyslexia. So they have problems with irregular words, and I'll lay that out for you. So words that when we spell them, we pronounce differently. So something like yacht, they might pronounce as yacht. But we know that these, as I mentioned, these are people who speak often quite fluently. Their content might be quite empty, but their grammar's intact. You often see them doing a Sudoku in the waiting room. So then their numerical knowledge is pretty good. And I've put in this area of strength that they often develop these favorite topics. And I think these can be a difficulty as well as a strength in day-to-day life. So I've met several people who then find it easier to talk on very specific topics, but that can become a real burden for the people around them because they can only talk about what they know about. So they often can't talk about things that other people in their family might be more interested in. So it can be both a strength and a difficulty. So just moving on to non-fluent variant PPA. So this is a disease that can be quite difficult to see on imaging, often quite subtle, but generally, again, left hemisphere affecting the frontal, insular, and anterior superior temporal gyrus. The underlying pathology is quite variable, but there's this idea perhaps that people with more pure motor speech, so apraxia problems, might have more of a pure tau protein, and then people with more grammar issues and agrammatism, and I'll unpack what I mean by that, might have more of a TDP43 protein involved. But either way, they're in the frontotemporal family. Okay. So what do you see when you meet somebody with non-fluent PPA or PNFA or NFV? It depends what acronym may be adopted. But one of the things we know, and I'm going to talk a little bit about a hallmark symptom, is that more and more we found that binary reversals are a real hallmark feature of this variant. So people will report that their family member reversed yes and no quite early on. We sometimes call this the Dibley phenomenon. So as in referring to the Vicar of Dibley, the character who would respond often saying, yes, yes, I mean, no. But we've noticed it doesn't just affect yes and no, it can affect other binary words, so like up and down or he and she sometimes. And what we are exploring more now, though, is that perhaps people from maybe more bilingual backgrounds, that this feature doesn't present quite as early for those groups, but it's certainly a real hallmark to look out for. And then what you see is this group presenting with an apraxia or an agrammatism. So that means that this group of people present with real effort and disfluency in speech. It's hard to articulate the words. So when you assess them, they will often find it really hard to move their lips and tongue and mouth in the way so precisely and as fast as you want them to, or they want to. And they may also present with an agrammatism, which then also means that they find it hard to use grammar and understand grammar. So initially that might be difficult with when they're listening to longer grammatical forms. They might find they don't understand what you want and where. So we often use quite complex grammar even in day-to-day life, and they might start omitting things like the or a or prepositions like on top of or under. So you might find people over time become more and more what we call telegraphic, so they omit all the little words and they end up with just the single words and the nouns, and that can be both because of grammar and because of the effort of talking. So it's can be really worth pulling that apart a little bit, because that has implications for interventions. I'm going to talk about logopenic variant last of all, but the majority of people with logopenic are associated with an underlying Alzheimer's pathology. I mentioned that at the beginning. When we look at imaging, we often see people presenting on imaging with real left hemisphere atrophy, involving the temporal parietal junction, as well as this early involvement of the hippocampi. And you can see that here on the screen. And people with logopenic variant PPA, they'll often say to me, this word is on the tip of my tongue. Okay, and this group find numbers really hard. They find repeating long sentences really hard. So these are the kind of two things that happen. We find people have real problems with sentence repetition and digit spans, and they describe this kind of tip of the tongue phenomenon. They can't think of the word, and when they say the word, they might assemble it in the wrong order. So they produce these paraphasias, like instead of saying animal, they might say manimal. And we attribute this to, and I've put on the screen here, a phonological loop disorder. And that's probably more of a speech and language term, but we also talk about verbal memory, a disorder of verbal memory where you can't keep those words in mind. One of my clients once said, it's like I'm trying to put things on the production line and they fall off as they go out of my brain or in my brain. So it's this kind of production line idea, which I thought was quite useful. So you can start seeing some of the differences across these groups. So just to kind of summarize, they do all have in common, people with language-led dementia present with a language difficulty, a speech language communication difficulty as a leading symptom. It's the first thing in their case history that people will notice. However, if their speech is more effortful or misarticulated, or there's these grammatical issues, that's when we're talking about a non-fluent type. If that's pretty okay, but they're having real problems repeating longer sentences and digit spans, we're talking about this logopenic type. If that's all relatively all right, but the main issue is understanding words, understanding the meaning of words, and they're, asking you what is a sibling, what is chicken, then we're looking at a semantic variant PPA. I should emphasize here, though, you know, we're not, as humans, we're not all square pegs fitting into square holes. And of course, not everybody fits perfectly into these categories or variants. And there's a large proportion of people, we think between 15 and maybe up to 40%, I suspect it's somewhere in the middle, to be honest, present with a more mixed or atypical type of PPA. So that's just a summary for you to reflect on. But what is clear is that people with PPA have language difficulties, and these language difficulties have a high disease burden. We know this even in the non-language-led dementias. They really contribute to this sense of isolation that people and their family members experience. And we feel it's therefore critical for caregivers and professionals to understand how to manage these difficulties, and that's reflected in NICE guidance, that's reflected in what we know from caregivers who that's the thing that people say. We've done lots of research and people always tell us, I've been searching for guidance on how to talk to my partner. No matter often whether they have a language-led dementia or not, they'll say, how do I talk to that person? How do I give them instructions? How do I look after them? How do I interact with them? And speech and language therapy is a key intervention that can help. So that's our bread and butter. We do communication therapy. So what is the current research field in this area? So I thought I'd summarize this to help you see where I fit in. So in general, there's been quite a bit of research actually on what I would call impairment-focused interventions. So I'll describe this in more detail, but where you practice words or sentences that's tailored to the person with the aim of maintaining them. And that evidence is there now. We know that if people practice words, they can practice personally relevant words, and they can maintain them through practice. Obviously not for the entire disease duration, but they can maintain them for a lot longer. There's little research on the more functional components of communication. But what we do know from the studies that have been done is that in general, these studies focus on, and by functional, I mean being able to communicate, participate in daily life, have a conversation, go to the bank. But what we do know about these interventions is that the interventions that there are, they all focus on an existing strategy. We found that actually in terms of behavior change, it's much more effective to tweak strategies people are already using, and to bring the communication partners in, to work alongside them, to support them as a team. And this is a very ecological approach, of course, because in general, the partners are not living with a progressive disease. And we found from working with speech and language therapists across the UK that actually, generally, speech therapists have reported prioritizing communication training, general communication guidance for family members. But back when I started my research journey, at that time, in 2015, 2016, most speech therapists were borrowing from stroke and brain injury literature to do this. So they borrow resources and try and apply them and use them with people with dementia. And of course, people who've had a stroke or a brain injury are traveling a very different trajectory. So many of these interventions really don't meet the needs of people with progressive disease. And this is what inspired me on my journey. And so on my journey, my focus has been developing an intervention we call Better Conversations with Primary Progressive Aphasia. And this is based on its sister intervention. It is based on an intervention for stroke aphasia. And this intervention has shown that in stroke aphasia, this type of intervention can not only change conversation, change communication behaviors, but it can actually reduce the risk of negative mental health outcomes. So essentially reduce the risk of things like depression in the person with the diagnosis. So I have developed the Better Conversations with Primary Progressive Aphasia intervention. I'm going to take you on a very brief tour, so you know I'm doing it in a rigorous fashion. So the intervention is based on research from the conversation analysis. So we've actually looked at how people have conversations, what works, what goes wrong. We've looked at behavior change theory. So how can we actually help people to do what we ask, or to do what we're suggesting? It's one thing us saying speak slowly. It's another thing, and all of us here, whether you're from research or health or social care or living with, you will know that speaking slowly can be actually quite tricky. So we looked at behavior change theory and chronic disease literature, and we worked with people with lived experience to co-produce a draft. And then we took that draft back to lots of speech therapists to make sure it was something they could deliver. So I should mention here, this intervention, Better Conversations with PPA, is an intervention that speech therapists deliver to a person with PPA and their family member. And we ran some focus groups with people with PPA and we integrated all of that into our refinement. And I piloted this intervention across 11 NHS sites. But I'm going to give you a bit of a summary of what this intervention looks like. So the idea is that having made a video recording, so we video people having conversations, some people raise their eyebrows at that, but it's very successful. People nowadays don't worry half as much about being video recorded, and we video record them having conversations. And then we talk to them about how conversations work. So we talk to people about what happens in a conversation, what can go wrong, and how that pans out in a conversation, and how people might feel about that. Then we show them some clips of their videos, and we reflect on their own conversations. So we support them to reflect and identify their own goals about what they're going to practice. What are the conversation behaviors that they could do more or less of? And I'll give you an example of that. It's not uncommon that we work with family members, and they find that they're using what I would call or describe test questions, so known answer questions with their loved ones. So a good example of that is if I was talking to somebody and I said, what color is my top? We all know it's yellow. It's yellow. It's a very pedagogical kind, a teacher student type question, not perhaps a partner type question. And sometimes that kind of type of question can really change the dynamic of a conversation and flag or highlight and bring to the surface a person's difficulty, because it's a test. You have to get the exact right words. Whereas if we work with people perhaps on enhancing behaviors, that I often work with people and they just don't realize how effective their gesture is in conveying information. And that's a very simple example. And so really showing that and practicing that and enhancing that as a strategy can be really useful. So what did we do? So we developed this intervention. We trialed it across 11 NHS sites. We trained 36 speech and language therapists who recruited people with PPA off their routine caseloads. They consented them. They completed, the speech and language therapists, the local speech therapy collaborators, did the pre-intervention assessments. And I've got a few listed here. And these were looking at language and quality of life, confidence, and also some with the partners, looking at burden. And we made video recordings of the couples before they had intervention, before they were randomized, I should say, to either have our svPPA intervention or no speech therapy treatment. And we recorded all of the intervention studies. And just to take us back a step, I should emphasize, sorry, some of the things we were interested in our pilot feasibility study was what's the best way to measure this intervention. So we're looking for the primary outcome measure. And we were looking for, if we video recorded all the therapists, could the therapists do what we told them? Could they stick to the protocol? And was randomization acceptable? And could we recruit people with PPA from the NHS? Would it be possible? And we then had blinded student speech therapists who would go and visit the person with PPA after that 4-week period, and they'd complete blinded, so they didn't know whether they'd had The students didn't know whether they'd had speech therapy, the svPPA or not. So they did all the measures again. And at that point, we collected all the data from everyone concerned, including, and I haven't mentioned this, the goals we set during therapy. So that's the design of our study. And I'm really gonna move on to results, because I think that's the most interesting bit, tell you where we're up to. So we actually had more than 70 potential participants for the study. We recruited about 22, but only 18 people finished the study. So we had to, unfortunately, our study, like many, many others, was cut short by COVID. But we had 18 couples who completed the study, and they rated it really, really positively. They really enjoyed it. They got a lot from it, and they told us the best bits. The treatment fidelity was high. The speech therapists, it was in the 90s, so they could do exactly what we asked them to do. So we knew that we could train people to deliver this intervention. And when we actually looked at the video recordings, so we videoed people before and after the intervention, and we coded their behaviours, and we had masked researchers look at what behaviours they were seeing. We had a very thorough definition of all conversation behaviours, and we saw changes, positive change in conversation behaviours that were being trained. And we found that the participants themselves, when they set goals, they were achieving or overachieving them. So, which we really feel indicates that they didn't necessarily feel they could always change their conversations. And when they did, it was more than they thought they could have done. We also identified a primary outcome measure, which demonstrated change in the right direction, and a quality of life measure. However, well, before I say however, I should say this was great. It was the first randomized controlled UK pilot feasibility study of this communication partner training for people with PPA, and it's really promising. We're very excited, and the svPPA intervention will be freely available on UCL Extend, and this has led to more questions, more research questions. So this is the however. So what we of course want to know is how effective, like, is it more effective than word training? Is it more effective than other therapies, and how much does it cost? What kind of investment are we going to make? And not just cost, but what is the kind of economic advantage to doing this kind of intervention? I would hypothesize that if we can show that we are reducing the risk of negative future negative health outcomes, like reduce the risk of depression, that's a pretty, potentially has it has implications for good cost savings more broadly for the person and our services. But we had some feedback from participants, and they said, you're not measuring what we think is the best bit of this therapy. So we really need to understand what do we need to measure? We think we're measuring the right things because we've seen positive change, but the people, the speech therapists, their family members, they told us we weren't getting to the nub of what they felt was the most important bit. We also wonder when should we be offering or delivering these therapies? We recruited, well, 22, 18 people finished, but there was a huge pool. And in general, the biggest issue was the fact that people were referred to speech therapy far too late in their disease journey, often when they had developed much more severe symptoms, and the priority wasn't necessarily about interaction, and so they couldn't necessarily benefit from this. And often people also were unable, so the partners weren't always able to participate in a therapy because they had their own commitments like work and other care things. So we're quite interested in when we should deliver it, and so I'm looking at delivering the intervention much earlier, recruiting people at much earlier phases, and also including delivering this remotely. So we had some feedback from people that actually, if this was an intervention they didn't have to attend in physical form, they could potentially take like an hour's break from their other work and care commitments to participate. And I deliver this type of intervention to people with all different types of dementia, and I have very positive feedback, really good outcomes. So we want to show, what I see clinically isn't shown in the research, and so I want to explore this in the research can we deliver this intervention to people with other types of dementia, and how much, what's the dosage? So this kind of leads me very nicely to let you know about my current research, which is I'm working to develop a core outcome set. So looking at how should we measure these interventions? We're collaborating with, at the moment, 19 countries, asking people with PPA and their family members what they think are the most important outcomes. We're also designing a care pathway with people with PPA, really trying to work out, well, where, this question of when people should be receiving it, we're asking people what they think these pathways should look like. So we're doing a big project around that, and also looking at the health economics of this pathway. But then we're also exploring the final the final feasibility questions that I outlined before. So we're doing a multi-site, hopefully to kick off in about 9 months to a year's time, looking at better conversations for people with PPA and other types of dementia. But I always like to leave or end my talks by reminding people about the voices of people living with this disease. And if anyone doesn't know about rare dementia support, I help out with rare dementia support. I co-lead the PPA support group with Professor Jason Warren, a neurologist, and Dr. Chris Hardy. And this is an example of the resources that we have on the support group website. This is Helen, who has PPA, and she's shared her journey and her experiences of her journey, but also of what speech therapy has done for her. And she is very eloquent in describing how speech therapy helped. I should also say that on the Better Conversations, I know that's a very heterogeneous audience, so there's some speech and language therapists out there who want to learn more about Better Conversations. We run lots and lots of training on communication partner training, and do just contact me if you have any questions or want me to point you in the right direction. But it just leaves me, this is my last slide, just to say thank you, highlighting all my lovely study participants, my lovely collaborators and mentors and supervisors. And I think that's the end of my talk, but Clarissa, shall I unshare?
Feel free to unshare. Yeah, that'd be great, Anna. Thank you so much. It was really interesting. I see some clapping hands, and yes, thank you, Anna, for that. We now have time for questions. So you've certainly been busy, but I know you've been busy, Anna. You always are, which is fantastic. And for me, it's great to learn more about different subtypes that we're not talking about too much, and that we as researchers ourselves don't actually come across that much when we interview participants, and even when we work with people living with dementia and their carers as public advisors. There's very few people that I work with that have had semantic dementia, for example. And I still remember the first participant I ever recruited with semantic dementia. I went to their home to do a neuropsychological assessment years and years ago. And he just couldn't bring his words out, but he was still so switched on in his brain. And that brought me nearly to tears, because he just wanted to say so much, but he just couldn't. So it is really, really difficult. I think it adds another layer to the difficulty of dementia, doesn't it?
It really does. And yeah, and I think often these clients fall between the gaps, and there's both my clinical experience, and I know there's a study, I couldn't tell you who it's by, that says there's probably often people have spent about 2 years trying to get a diagnosis at least. Bouncing around. I've had clients who've, clients are it's often attributed to anxiety, depression, especially if clients are quite young. I have clients, PPA can happen, it's considered often a younger onset, but actually I have several clients with PPA who are much older, but I have people who range from their 40s to their 90s with PPA. But I think that means that several of our clients end up bouncing around services. What has been useful is that sadly Bruce Willis has been diagnosed with with a primary progressive aphasia. And actually that certainly led to, amongst the clients and participants, my research patients and my research participants and my therapy clients, it's actually, people talk about it as being really helpful to explain to other people. And we have slowly seen a couple of people coming through clinic saying, I thought my mum was a bit like Bruce Willis, or I thought I might be a bit like Bruce Willis. You know, that kind of that kind of awareness raising has been really helpful, I think, for this disease.
No, it's sad, but if it raises awareness, I suppose the same thing that, I don't know if Jackie Cannon is on this call, but the CEO of the Lewy Body Society, when Robin Williams sadly passed away, and he was then found to have Lewy body dementia, again raises awareness of a rarer type of dementia. I've got a question, whilst other people can please post their questions in the chat function. So just thinking from a care point of view, if someone has a PPA and they want to access some support groups, they want to access a daycare center, maybe some respite care or a paid home carer coming in, how is that? Do you know how that's working? Because it must be particularly difficult for social care staff to support people adequately then.
Yeah, absolutely. And I spend time training healthcare, social care professionals. And actually one of the, so I clinically, I spend some time often, I have met with health and social care support, privately employed PAs, whatever the creative or more organized way that people have organized their support. And I've given them tailored guidance and training. And communicate. We've even done the full communication partner training with some of those people. Other times we've built this into the Better Conversations with PPA model in some respects, in that often within the domain of future planning, depending where people are in their journey, this has included planning what you're going to share. And in the first instance, it can be planning what I'm going to share. We might do communication partner training with the person's spouse or life partner, but often they'll say, but what should we tell the neighbor or our children who can't come? And so we spend time planning how you're going to share this with those people, whereas at the end it might be, how am I going to share, or further along the journey it might be, how am I going to share it with the carer who's coming in or the rest of the team. So we try and build that in, but you know, of course, I think one thing I haven't talked about is access, and that's a genuine thing. It's important to mention that access to these types of services costs money, so and time, and not all speech and language therapy services have the resources to provide this volume of education, advice and training, and neither do necessarily the care workers have time to do the work or talk to us themselves. So it can be tricky.
So that's in terms of, and I know there's some question about whether Admiral nurses can access that training as well. But if someone then gets a PPA diagnosis, which can be very delayed as well, do they then get generic sold access, or do they get anything? Or is your feasibility study kind of the first one out there to support people better? Yeah.
The short answer is there's no standard. There is no there's no care pathway, and my experience has been that lots and lots of people still do not get referred ever to speech therapy, perhaps because for several reasons. One might be because the local service has only got provision to do provide swallowing support, or another might be because and of course I should add here that speech and language therapy is accessed often through medical or nursing, or a referral from another healthcare professional generally. So it might be that healthcare, the GP may not know that we do this with, we may know. The other thing, to answer your other question about Admiral nurses, this is an intervention designed for speech and language therapists to deliver, but you're thinking ahead. You're anticipating our every move, and it is something that we are interested in developing further, is training that other healthcare professionals could use to deliver to people with dementia. And I think what we'd like to do is show it definitely works first, and then we move on. But there's so much work to be done in this domain.
But clearly really important, because lots of comments are coming in as well. So really, really relevant. Gareth has asked a question about whether it might be too late for his partner with PPA to use this option that I know it's a study and it's closed for now, but how would someone know whether it's too late to get engaged with this?
So my short answer is it's never too late to see a speech and language therapist. So I've given very specific examples in my talk about which are verbal examples, but I often advise people on using non-verbal examples. So just recently I was working with a gentleman and his partner is now in a residential facility. She really only says a couple of stereotype phrases, and the communication partner training actually focused more on non-verbal interactions. And so, for example, what he realized, so he arrived at the therapy saying, what does she mean by this stereotype phrase? And by the end, he left saying, oh, now I understand that her tone of phrase, so often listening to her tone or her facial expression, he was able to recognize that actually that she was turn taking. So the tone was indicating she intended a question, or it was a positive statement, or is a frustrated statement. So doing that work around actually, I guess, and this is the words of another client and their family who I work with, which is rather than listening to the words, looking to understand, and then working out how that people can interact, take turns non-verbally too. It can be really important to focus on that right till more profound stages.
Okay, so definitely important at any stage and at any awareness, even if we think there might be something, approach someone to have a chat about it in a professional manner. So we've got a question by Emma. She'd like to know more about how to support sign language users with PPA. Are speech and language therapists aware of how to work in a visual language?
This is a really nice question, very niche, and very important. And my advice would be there is no research evidence on speech and language interventions for people with who are sign language users. Well, there is one case study where a lady who had PPA had already learnt to use BSL, actually American Sign Language, because she'd been a carer or worked with people who use sign language, and she was trained to use a communication aid and sign language, and actually she found it easier to simplify and continue with her with sign language, but actually to use so she modified her sign language over time to be more I guess I'm probably, so it's not my area of specialty, hearing, but to use more symbolic gestural meanings. But I would say that not every speech therapist would know how to do this, and but it's really worth talking to a speech therapist nevertheless, because often it's not, because sign language is of course a language with grammar, and it's really it will become more tricky for the person to use. So there may be lots of creative methods people can think about, and certainly visual aids, alternative visual aids.
Great, thank you. I see quite a few questions from, I think, carers or family and relatives who are really concerned about the lack of information that's out there if their relative has PPA. So where can they find more information? I know you've just flagged up your the website of Rare Dementia Support, which is fantastic, and there's some more PPA, but also other subtype information, Parkinson's disease, dementia, Lewy bodies, etc. So that web page is there, but are there any other avenues where people can find help and guidance and documents?
It's a really good question. I'd say that the Rare Dementia Support website is a really good place to start. There are videos of people with lived experience. There are videos of our seminars. You can sign up and see, have to webinars and support group sessions, come down and meet other people, speak to the help team. They can tip you off. There are local, depending on where you live, there are local support groups, which many of which fall under the Rare Dementia Support Group kind of governance. Increasingly though, Alzheimer's Society, I was talking to one of the content writers from the Alzheimer's Society website, and they're refining the information they put onto their websites because they don't have very much, but they're looking to improve that. There isn't very much is I'm afraid the answer, but there's more coming. So maybe start with those bigger organizations, because the risk is if you look at some of the less well-known, you might find it gives you information that is harder to use.
So we've got one question from Lisa, who is a dementia advisor for people under the age of 65 in Derbyshire. Is speech therapy readily available for people living with dementia who are so young, or is it more complex because of the diagnosis?
That's a great question. And it's a question I get, I'd say every time I do a talk. It's a very reasonable question. So there are speech therapists. The speech therapy it's a postcode lottery. That's probably the simplest way to put it, but it's improving, and more speech therapy services are able to deliver speech therapy to people of any age, and not just for swallowing, but also for communication difficulties. So it is improving. It fluctuates, of course, but if you're ever unsure, and you don't know, you've asked your GP or you've asked around, do get in touch. I'm happy to put my email address. I think my email address is on the slides, but I can put it in the chat. And I do spend time, that's part of my role, clinically at the National Hospital. I do a day there a week, and part of my role is connecting people. So I often spend time connecting people with speech and language therapists across the country. We have a UK-wide speech and language therapy network for speech therapists who are interested or work with people with primary progressive aphasia. So sometimes I can use some of those connections to find a relevant speech therapist, or through charitable organisations there's a charity called Discover with a Y, DYSCOVER, sorry, and they're the only charitable organisation who provide speech therapy to people with PPA. They're based, this sounds awful, but I'm very London centric, so they're based down under London, but they cover a larger, relatively, so south, but they cover a relatively large geographical area, but that can be useful as well. But I can point people in the right direction.
Great, thank you. I think there's we'll have a look at the chat afterwards as well, and I see that some of the carers on this call are also providing a little bit of signposting here, which is really helpful. But unless there's any other key question, lots of comments, Anna, so we'll have a look at them afterwards. But I think those were kind of the key questions from everyone. And just to remind everyone, we will be uploading this talk on our ARC Northwest Coast YouTube channel afterwards as well. So you can look back because there's been a lot of information that Anna has given, which is fantastic. So I'm going to do a little clap of my hands because we're all virtual, so we have to do it that way. So again, thank you, Anna, for this. And if you could share the final slide, would you mind, just to make people aware of the next talk?
That's wonderful. Thank you. Oh yes, that's sharing.
The November webinar.
So here we go. Hold on. It will help if I. There you go. There you go.
Super, thank you. So moving on from language-led dementias to more generic social care. So in November, we'll be joined by Professor Anne-Marie Towers from Kent, and she'll be talking about capturing the impact of social care on older people's quality of life. She's been really busy working on a tool that's called Ascot. She'll be explaining more, but I think it's interesting to hearing different topic areas from the more clinical side of view that Anna has just provided, to then move into, well, how does it work in practice for older people, people with dementia needing care access, and maybe there's some linkage there as well. And we've already got some lineups for the new year, some Liverpool-based researchers who will be talking about music interventions in dementia, but also about Parkinson's disease, dementia and hearing loss. So we've got quite a few talks coming up, but thank you everyone for joining. This is it, and hoping to seeing you at the next webinar. Bye everyone now.